Okay, I'd like to thank our speakers for 3 provocative talks about how we might change our ways of thinking about how to address the challenges of our changing world and improve our listening and auditory experiences. I ask the questioners to make their way to the microphones.
Hi, I'm Matt Quinn from the FCC, and prior to this, I was at NIST working on standards around usability of electronic health records in the health IT. And one of the things that we found was that often thoughts about user-centered design and human factors were an add-on later, and thus never really truly incorporated. How do we change that perception that, you know, the difference between a hearing aid that someone loves, or a hearing device that someone loves, or an electronic health record that somebody loves, or a mobile health app that somebody loves, and one that has all the function that they might need and that they discard and don't use, or that they go constantly back and forth to the audiologist, is the human factors of it?
You nail a problem that is an intractable problem. And I think part of what we're dealing with is an attitudinal problem. The idea that this has the potential of pervasive value to a large portion of the population is still, it's a door we've been unwilling to go through. We have attitudes about aging and we have attitudes about disability where we have identified a comfort level. We aren't old until we're at least 80 at this point. Yeah. Our systems change a lot further, a lot lower age range than that. But I think we've also believed that somehow the notion that this was an investment for all of us and that we all had a stake in it is very tough for us to act on, to live with. I work a great deal in Japan, and the Japanese have a very different attitude, and they are getting into the research and development phase at the very first conceptual conversations. They are doing it because they feel they have a stake in figuring out how to maximize independence for as long as possible. But they all feel like they have an obligation as a culture in an aging society to make a difference in that way. We're struggling there. I think the attitudinal challenge is the thing that is the toughest to get people to appreciate. So it's still perceived as special and over here and not central to the ordinary product.
Until they need it.
Until they need it.
One follow-up. You talked about the challenge of disruptive type technologies or approaches, and one of them that I would like to highlight is some of the work that Greg Vanderheiden at Wisconsin is doing, something called the Global Public Inclusive Infrastructure, or GPII. And this is the idea, as opposed to trying to have a one-off product that fits everybody kinda, that you have a auto personalization served from the cloud. So leveraging, storing your personal preferences and other things in the cloud, and then every time you touch or sign into something, that it automatically personalizes this. How we go from a marketplace that it is today, where you're selling individual implements or regulating individual implements, to one that is different for every person potentially, I think is going to be a challenge. Any thoughts on how we make that transition, or if that's an approach that's out there today in the marketplace?
I think anybody who's a global player is so sick of the incredible complexity of life if you don't get to that point, that it has become not just a dream, but something I think we have to tackle. On the Greg Vanderheiden issue, one of the other things he's done is try to contribute to the idea that we've got to share data and try to make this argument across the board, and it's aging and ability and culture. And he has a website also called Raising the Floor, which is another good resource.
Thank you.
If I can add a comment, I think it's critical for those who get heavily involved in these processes, whether it be health records, whether it be hearing aid compatibility, to be continually alert to who's not in the room and then reach out. I got in an interesting conversation with my personal physician who I've been going to for 25 years, a wonderful doctor. And he commented on, from his viewpoint, the health records that the new standards are taking us to are not very useful to him as a doctor, but he and his partners, with their scribbled handwritten notes, communicate what they really need to tell each other. Whether he's right or wrong, that's a voice that needs to be in the room. And I can tell you, my doctor doesn't feel he's in the room, and from some personal observations, I think there needs to be some outreach. So, you know, it's constantly, who's not here, who needs to be here, and then taking the effort to go talk to them.
I'm with you.
Noreen Gibbons with High Health Innovations. I want to thank Stephen. I agree with your comments. Regulations designed to protect us can also prevent a lot of innovation. At the same time, I'd like to ask David and Stephen, and maybe even Eric, if he's still in here, a little bit about the devices that we saw from Sound World were, I'm assuming in the U.S. marketed as PSAPs, because as you probably all know, there is an issue with the FDA allowing a self-assessment tool like a hearing test done on those devices to be tied to the purchase of a hearing aid. I'd like to hear some comments about that if I could.
I'm going to have my colleague Stavros respond to that question.
We are not making a hearing assessment, neither a clinical audiogram. We are just trying to figure out, to help the person figure out easier his listening preference. And we don't really indicate anything in there that we are taking a test. The fact is that we give the people tools that after they do some assessment, to actually equalize it. So it's a personal equalizer more than anything else, and the people have access to the controls so they can adjust it while they're wearing the device in different environments. What we were overly concerned is to limit the output of the device. So when the device is sold as a personal amplifier, we do not allow an output more than 160 dB. To make sure that even if people make an error in adjustments, that they are not going to damage themselves. And we think we are much more conservative than many of these headphones that people are wearing out there, that the output really goes completely uncontrollable.
I'll add a comment to that. We originally designed this product for emerging markets, for very resource-poor environments. And so we had to come up with solutions to serve those markets that presently don't exist. So if you think of the availability of hearing aids and audiological assessment in the emerging world, it's very, very tiny. And so we had to come up with business models and technology to serve those business models to convert that great unmet need into demand for better hearing. So we actually took the help of a design firm, IDEO, to test out some of our assumptions about non-medical technicians and their ability to use our system to fit our device, and that helped us in our whole design process. We did that research in India. So each step of the way, we were focused really on addressing the great unmet need in emerging market and how we use quality and price and accessibility and ease of use to convert that need into demand.
Well, just as a follow-up, we tend to think of people in other countries, which is wonderful. I'm glad we're thinking of them as well. There are a fair number of Americans who, as the High Health Program will definitely show you any time, and we'd be happy to talk about that more, that there is an access problem in what some people might call flyover country. I mean, we don't all live in big cities. We don't all have audiologists around the corner. So I applaud you for recognizing that need, and the assessment part of it is an issue. Now, I had thought that the NL2, I had mentioned earlier with Frank Lynn about how the devices were being set up, what sorts of, if any, prescriptive formula was being used. And so my apologies, but I thought it was based on some pure tone assessment. It's not based on any sort of pure tone assessment through the device then.
Yes, we do a pure tone and a wobble tone presentation of tones, and we're asking people to respond if they hear the tone. It's a very intelligent system. We are testing different frequencies depending on the person's response on the sounds that they hear, and we are continuously monitoring the environment just to know that the accuracy of the measurement is good enough, because if it's in a noisy environment and the person's threshold is very close to that environment, then we tell them, to go to a quiet room. But this is really an issue of a starting. We are not trying to make a clinical evaluation of the loss.
I'll add to
And
that.
besides, we all know that in hearing aids, it's thresholds really, it's only a starting point on how to actually adjust the response of the device.
We're just starting. We're iterating to address a huge problem. And in fact, I was thinking today we should change the name of our product to the Cognition Enhancer. So when I set out developing eye care with all my partners, we didn't know where it was going to lead. We didn't know the transformative effect that affordable intraocular lenses or sutures would have and the effects they would have on the markets. So keep in mind that everything that we're doing is an experiment, and it's about serving people. It's about serving the constituency of those that have difficulty hearing. And we don't know what, as I look back in eye care, we had to navigate quite a few regulatory and professional landmines, which we were able to really increase the affordability, availability of eye care, in this case, people getting their sight back from being blind due to cataract. And so I'm sure that will be the same adventure that we embark upon with hearing. And we hope to shake things up, yes. We hope that hearing aid companies and audiology will join us in really shaping different market forces that serve a much greater number of people, because I think, as Dr. Lin and others have been alluding to, hearing, the ability to hear well has quite an effect on your cognition, we think. They're certainly related. What comes first, it's hard to know, but I think that this is a really important arena, and I'm sure that there's going to be lots of difficulties and fights and misunderstandings, but I think that we all have to think, okay, well, what's an ethical, legal way to be approaching this problem, even if we're not always in agreement about the different approaches.
Also, there's an issue of what is normal. We tend to think of a person who has a hearing loss more than 20 dB is not normal. Well, normal for a 65 or 70-year-old, normal could be 40 or 50 dB hearing loss, and it's perfectly normal, because as we age, we have deterioration of many functions of our body. So then giving people access, the ability to adjust the device to whatever their needs are, and eventually will make them two things. One thing is will make them aware, it will give them access to something that they can try on, and very quickly they will realize that they probably need much more than that. And so it's an excellent device and that's what we intend to use it in this market at this point, to make people aware, like the reading glasses, to make them aware of how much they need to actually, if they need more amplification, and how much they are missing by not having amplification in special areas where they need it.
In closing, I want to say thank you, because I actually, as a clinical audiologist for more years than I'm going to admit, it is an incredible need out there. So innovation in hearing healthcare is definitely, as we've heard, but a lot of opportunities meeting people where they are, and that doesn't mean geographically necessarily, but is a big challenge for us. There's a lot of opportunity. So thank you again.
Next question.
Yes, just one element of design that we haven't talked about today, and that is some of the special issues that older people have in using these devices. Cindy was talking about the pocket talker, and for some 80-year-olds, that's about the level that we're talking about. So when we talk about, for example, using cell phones as a hearing device for someone in their 80s, it's not happening. You know, we have to design very simple technologies that someone can put on. I can tell you from my experience with older parents, they're very intimidated by cell phones. We actually have pictures of my mother's cell phone and her remote control for her TV set. Now, this may sound surprising to you, but my mother very often mixes up the remote control for the TV set with her cell phone. So this is the level we have to be thinking about. We haven't had that discussion today. We really need to be thinking about hearing devices that the older aging population can put on and use. If they can't operate it, they're not going to use it. It's not going to work. We're talking about hearing aids. We're also, frankly, talking about cochlear implant processors. And I've worked through the use of cochlear implant processors with many older people who, when it's on and it's set properly, they get tremendous benefit from it. But sometimes they can't operate the controls. They don't have the manual dexterity. There's too many buttons. So a plea to everyone to please put this into the mix as we're thinking about it. We're talking not about 60-year-olds who are used to using computers. We're talking about older people who very often don't have that, and none of us have really brought that up in the past 2 days. We need to be thinking about it.
Wrap up comment?
Yes, just a personal comment. My wife
No, I meant from,
is...
I'm sorry, I meant from the speakers to address.
If I could just speak to the concern, which is a very legitimate concern, one of our reasons for creating really building the capacity to offer real people to test ideas and products and prototypes is because the designers and the industry have found it so difficult to find humans across the spectrum of ability, including much older people who are quite fragile. There is no substitute for actually doing testing with real people. And understanding the plethora of issues that can be impediments that you can easily miss. And it happens day after day after day. I can't tell you on the sight world how many design firms decided in products for people with low vision, they would test one person who had low vision. What does that tell you? Not a thing. There has to be an understanding that users have got to be involved in the process. And I think that just has to be something that is insisted upon in every possible way, in whatever process where we can influence how people think about these things. But the idea that humans are difficult to find, who have functional limitations, is a tragic confusion.
I apologize to the remaining questioners in line. I'm getting the hook sign from Tracy so I can turn the podium over to her to tell you about lunch. Thank you.